Welcome to the Andrew County Ambulance District Patient Care 101 video. The latest release was February 2016 for this video. This is part one of two video presentations. The second part is Documentation 101. Disclaimer, every patient presents with different situations. This presentation is designed to be a refresher of patient care priorities that have been reviewed during the QA process. I am by no means trying to dictate every aspect of how you do your job, but feel it is my responsibility to point out situations. I consider this a good review. In general, when you respond, all responses should be of an emergent nature. Lights and sirens do not have to be used to be an emergent response. As long as you get the call and make immediate steps to handle that call, it is considered an emergent response. Driving with lights and sirens in a safe manner for the community will generally give the impression that you are taking the call seriously. If you respond to somebody's house for a fall and you show up to the house not running lights and sirens, that may give the impression to the community, because they have a general expectation that lights and sirens are used when there is an emergency situation. Most of this is going to be based on the EMS treatment guidelines of Andrew County Ambulance District. The primary guideline we're going to look at first is 100-02, the General Patient Care Guideline. Scene assessment, you need to make sure your scene is safe, and then you need to make sure that you don't need initial help or any specialized help, and always have your BSI on. Primary assessment, the first thing you need to do is you need to consider any associated trauma. So look for inline immobilization and then a properly sized C-collar if necessary. You need to assess the level of consciousness on the patient. That's assessing the alert, verbal, painful, and unresponsive, and also the GCS of the patient. Ensure a patent airway, whether you need to do a head tilt jaw thrust, use a nasal airway, oral airway, possibly using continuous positive pressure, maybe a King airway, maybe endotracheal intubation, and then even up to cricothyroidotomy. You need to assess breathing, ensure that there's an adequate rate, depth, and effectiveness of that breathing. If not, assist, possibly CPAP. You also need to ensure that the patient is having good oxygenation. If they are low oxygenation, nasal cannula, non-rebreather mask, and then assessing lung sounds at this general time. Assessing circulation. Also looking for bleeding and life threats. When you get to the secondary assessments, we look at the initial set of vital signs, a head-to-toe physical assessment, history of present illness, included your sample history, your OPQRST for pain, 4, 12, 15 lead EKGs, blood sugar if any decreased level of consciousness. I cannot stress enough, and you will probably hear it several times in these two presentations, blood sugars on any decreased level of consciousness patient. In our protocol, we have 4 reasons you can start an IV access. You can start that if you have to give fluid replacement or generally believe you're going to give fluid replacement. A medication route, whether you give medicines or whether you potentially might give medicines. Traumatic injuries requiring fluid resuscitation. And the last one is just the general discretion of the paramedic or the RN. Pretty liberal. You can start an IV on just about anybody you want to, but you don't have to. Once you get to that point in the protocol, it says to follow appropriate protocols. This is when you would branch off and go to a different protocol and find your way. After you complete that protocol, then you're going to come back to the ongoing assessments and transport, which is going to be monitoring the patient's condition, reassessing the vital signs. If they're unstable and the vital signs are changing frequently, or they're in a serious condition, you're looking at every 5 to 10 minutes. If they're stable, every 15 to 20 minutes. All patients should have a minimum of 2 sets of vital signs recorded. And then you also need to contact that receiving facility. I wanted to take a few moments and make a few comments on some various guidelines. First of all is 200-16, which is our chest pain protocol. 12 lead should be on all chest pain patients. A 15 lead if they have any inferior lead elevation, or if you just have any unexplained reason for chest pain or discomfort, you want to put a 15 lead on there. The protocol itself says morphine for chest pain. Dr. Davis has said that fentanyl can be used instead of morphine, but she was very clear that it is one or the other. Once you start using fentanyl, you can't switch to MS, and if you're using MS, you can't switch to fentanyl. You pretty much got to stick with one and ride it out. If you want to switch, you can always call medical control, but you need to stick with one. And I still prefer morphine because of the cardiac effects besides the pain control. 200-22 is our altered LOC syncope. Really, the only thing that says on that protocol is ensure the patient is not hypoglycemic. And again, I am stressing all patients with any ALOC, altered level of consciousness, should have their blood sugar checked. If you document a GCS of 14, they need to have their sugar checked. If you say that they're confused in any manner, they need to have their sugar checked. Any altered level of consciousness. Our 200-36, which is our respiratory distress, albuterol is for bronchospasm. Just because they're having shortness of breath doesn't mean they automatically get albuterol. Generally, you should have a clear picture, emphysema, or asthma. The best way to do this is in capnography, and the capnography waveform, which should be also attached to your strips when you turn in your paperwork. Just as if you do a 12 lead and you're basing your STEMI off of that, if you say your capnography and you say, well, the waveform was bronchospasm, you need to have a copy of that strip attached. The pulmonary edema part of the respiratory distress protocol is CPAP, nitro, and Lasix. Lasix is the last one on the list. Lasix is not going to have any quick benefits for the ambulance provider, especially as close as we are to the hospital. CPAP's the treatment of choice, and then if they are having a lot of fluid, nitro is really the medication of choice. 200-42, which is seizures. Anyone who has had a seizure should have their blood sugar checked. It is a brief altered level of consciousness, and they need to have their blood sugar checked. 200-44, which is our medication overdose, lists specifically narcotic overdoses. In narcotic overdoses, Narcan is used if respirations are inefficient. Push enough to increase respirations. The goal is not to wake them up, it is to make them breathe. And that is exactly what it states on the protocol. And this has been confirmed in conversations and in emails back and forth with Dr. Davis. If they are not breathing, that is when we give Narcan. We don't give Narcan to just wake somebody up. We don't give Narcan to take away their buzz. If they are maintaining a patent airway and they're oxygenating well enough and have good respirations, they do not need Narcan, period. If you feel you have to give Narcan for some reason to a semi-conscious patient that's breathing, you need to call medical control rather than use your protocol for that. And it's still going to be reviewed. Speaking of that, in the EMS guidelines, 2 people decide the appropriateness of the use. Ultimately, the medical director decides, but also the ambulance director decides. I've had a lot of heartfelt thoughts on this subject. Dr. Davis, I will say, with the protocols and the guidelines, is a lot more liberal than I am. I am a strict black and white. If you go outside the protocols, you are going to be in trouble. Dr. Davis basically feels if she would have done it in the ER, or if it was ultimately better for the patient, she is okay with it. I will say I would prefer that not to be the case. Obviously, if time is of the essence, I understand some leeway there, but you always have the opportunity to call medical control to get orders if you need to do something different than what's in the protocols. So my general advice is the best way to stay out of trouble, follow the protocols. If you have to stray from the protocols, call medical control via online. Uh, some final thoughts I have. My main thought is reading during QA, why do we allow patients to suffer? We say we treat people like we would want us to be treated. We say we treat people like we would our family. But I see people walking people with hip pain and leg pain. I see people walking people with chest pain and dyspnea. And I see other times when we don't give pain medicines when there's pain. I know sometimes there's a 20-year-old male patient with a history of drug abuse and back pain for 5 years. I can understand maybe not giving pain medicines to that person. But when you've got an 80-year-old female patient that fell and's having severe hip pain, that her hips shortened and rotated, or something in this case, why are we not giving pain medicines to help them? Our main objective is always to get the patient to the ER. I ask that everybody remember that we are not doctors. I ask everybody to remember that this is emergency medicine, and not every patient has to have something done to them. Don't keep looking for something that just, oh, I could possibly do this, or they could possibly do that, or I'm not really sure what's going on with this patient, so I'll just give them this. If you don't know, stick an IV in them and send them on the way to the hospital. And if something changes, then you can deal with it or get some advice from medical control. Don't start guessing and throwing darts to try to figure out what's going on and what you can do for the patient. I thank you for this short presentation. Again, this goes hand in hand with the Documentation 101 presentation. Please review that one also. Thank you very much.